Dr. Ouma Oluga.
Yes.
Karibu sana to the Situation Room.
Asanteni sana.
It's good to have you. Dr. Ouma Oluga is the Director of Health Services at the Nairobi Metropolitan Services. Hey.
Thank you.
The last time you were in the room, you were not working for the NMS.
I think I've been here before.
Yes.
Yes, you have.
Once.
That's what we're saying.
The last time you were in the room,
not working.
You were still a freedom fighter.
you were still a freedom fighter. And then the last time you spoke to us, you were working for the NMS.
Yes,
And you
yes.
just taken up, and there was all these things that were
Yes.
taking place. I mean, there is COVID.
Yeah,
Nairobi is the
there was COVID.
epicenter.
Yes.
And NMS is just taking over from the Nairobi City County.
Just
and
right.
Dr. Ouma Oluga has moved from the trenches. He has come and been told, okay, those things you've been fighting for,
Come on,
Do
so you do them. So there was fire all over.
Yes.
But it's good to see that you survived the fire.
Thank you.
And there's a lot of progress that you've made
Thank
with
you.
regards to access to healthcare in Nairobi. And that's what we want to discuss today. 24 new health facilities, that was the plan of the Nairobi Metropolitan Service. Establish new health facilities from the ground up, no, from the foundation up. And then have people starting to use those. So far, well, the last count, you'll tell us, I think about 19 were already in operation. Is it
15 already commissioned.
15
by the
already
president.
commissioned by the president?
Yeah.
And already operating.
Yeah.
And I think this is, we keep asking ourselves this, must be the first time that we see in this country one area receiving so many health facilities within such a short span of time.
Yeah.
And it also speaks to the failures of various past administrations in addressing the healthcare needs of their people. But we'll talk about that as we go. So those 15, where are they? What level of facility are they?
Yeah, so thank you for this. First is, as you said, the last time I was here, I think we were just starting, and NMS was just established at the same time that COVID had its first case announced, and so it was a very difficult time. Those first 3 months, from 18th of March, so Nairobi as the epicenter, there was the whole country was a bit scared, and we were right at the forefront in terms of that time. The major thing was quarantine. Remember, people were traveling from out of the country into Kenya because nearly every country was like bringing back their nationals. So the main thing then time was quarantine, and there were thousands and thousands of Kenyans who were coming from the countries outside, and that was the big work then, and we didn't have capacity, and then of course we were also preparing for the surge in cases, and now Nairobi we've had 4 waves from that time. And I think the first wave was a bit hard because we realized we didn't have nothing. And thanks to His Excellency the President and the Lieutenant General Badi, trying to go around, and we realized we didn't have nothing. We didn't have anything, because you want to set up a 300-bed capacity facility. You want a place to quarantine thousands and thousands of people, and you don't have a thing. The saving grace then was the schools and the KMTC, and we had to take over KMTC here in Nairobi, KMTC Karen, the Moi Girls School, the Nairobi School, Lenana School, the State House Girls, to use them as quarantine facilities. But also it was quite a huge indictment in the health system, because then you can imagine when you need the health system most, you have to run to schools. So what it meant is that then if children were to be in school, or if students were to be in school, there would be
We
nowhere.
wouldn't have the centers.
So in fact, it was good that the schools were somehow closed, and then we could use those institutions. But also the other thing is that when you're looking at informal settlements in Nairobi, Kibra, Mukuru, Mathare, if you go to Ngomongo or Korogosho, if you go to Kariobangi, Gatina here in Kawangware, you see the way in which the informal settlements are organized, the shanties, 5 people living in one shanty, and they are barely 3 meters from each other. If you're going to do quarantine, or if you're going to do isolation, if you're going to do home-based care, it's impossible.
Yep.
So you realize that at that particular time, we had to quickly think through what is it that is going to save this city from the mess, because, COVID alone was such a huge headache. And then you go back to now the historical health problems. You find 47% of Nairobians have been walking to Kenyatta National Hospital as their first hospital
The first point of
care,
call.
the first point of call. So someone walks from Kibra, they go to Magathi, but Magathi is a bit congested. They have to wait longer, so they just walk to KNH. The same with people from Kawangware, all the way down to Dagoretti. If you come to the Eastlands, the only hospital is Mama Lucy Kibaki Hospital, which was a small hospital, 132 bed capacity hospital. Of course, now we've expanded it, added another 66 beds. We're even expanding it more. But still, that is a small hospital for a population of 2.1 million people in the Eastlands. So that is the only public hospital, because Pumwani Maternity, which is also on this other side of Eastlands, of course, the Kamkunji, Isili area, is a purely maternity hospital, and it's the biggest in East and Central Africa, but it does maternity work. It doesn't do when you have an injury, you are on a motorbike, Pumwani is not the place for you. So Mama Lucy Kibaki was the only hospital. So you already have a congested hospital, you are having COVID, which you need a lot of people to be treated. All these people, all the way from Kangundo, which is in Machakos, which is the other level 4 hospital run by Machakos County government. The next hospital is Mama Lucy. So you can imagine how much pressure there was. So the people who are in Madare, who are in Kayole, who are in Omoja, all the way to Isili, if they needed something, take a taxi, Mama Lucy is full, go to Kenyatta. So this was the biggest problem. And so the way to sort out this issue, and again, thanks to these efforts, is we analyze and we realize that the best way to sort out the issue is to give people smaller hospitals that are where they stay. That's how the idea of the 24 hospitals came about.
So Mama Lucy is level 4.
Mama Lucy is level 4.
And now the others that you've built, are they? Is there any that is level 4? Are they all below?
They are level 3B. The others that we've built. So there are 2 categories of the hospitals. They are level 3B, and then there are level 2. So, but what we are calling level 3B, if in terms of service, is essentially what we call level 4 in county governments. So this
level 3 plus.
It's a level 3 plus, basically.
And even at the top of the levels, before we go on, could you break down these levels for us?
Yes.
And explain to our listeners what level 1 is, level 2, level 3, level 4, 5.5, and so forth.
So basically, Kenyan healthcare system is organized in 6 tier, or 6 levels, if you wish to call it that. So level 1 is what we call community health services or community health units. And this is not everywhere. Sometimes there is no actual physical structure that you are calling a level 1. But in some instances, sometimes here in Nairobi, sometimes in the upcountry, you find smaller dispensaries that are more sort of centers where they organize community health services. And when you talk about community health services, it's more about mobilization for issues such as immunization. Is where people go for barazas, and then you have the level 2. So the level 2s are the dispensaries, so to speak. So at this particular point, they start doing primary healthcare. And primary healthcare, in our case, is the main diseases: malaria, TB, HIV services. You again now have expanded program for immunization, or AP, and then you have at that level you have mainly what we call community health nurses, or public health nurses who are also focused more on education for the risk factors for pregnancy, for example. So that's where women are taught, if you see this, then you should take this precaution and such. And then you now go to the level 3s. And the level 3s, this level 3A, and then this level 3B. So the level 3A is a health center, where you have clinical officers, you have nurses, but you don't have a theater, you may not have imaging. Basically, you don't have an X-ray there, you don't have an ultrasound, you don't have a theater. And then for us, we have done the level 3B, where now you have the doctor. Each of our hospitals have 5 doctors, 5 clinical officers, 39 nurses. We have 2 theaters, basically a minor theater for small injuries and a maternity theater where you can do cesarean deliveries and even other operations. You have an X-ray, you have an ultrasound, you have a level 3 laboratory, and the level 3 laboratory means you can do, biochemistry test. I think that's the main defining factor. And you can also do the full range of complete blood counts.
But actually, if I may just interrupt, level 3A, some of them have a semblance of labs, don't they?
They have labs, but they have a lab that they can't do biochemistry. For example, biochemistry means they can't do liver function tests, they can't do kidney function tests. So if you have someone who needs what we call urea tests, just to check the status of their kidney, they can't do that in a level 3A.
But in 3B they can?
The 3B we do.
Okay.
Yeah.
And then now 4.
And then now level 4. So now level 4 is where you start having specialists. So now you have the main 8 specialties in surgery and also in medicine. So there is where you have obstetricians. That's where you also have internal medicine specialists. You have pediatricians, and then the full range of surgical specialties from ENT. I mean the ear, nose, throat specialist. You have the eye specialist. You have the general surgeons. You have what else? Basically the surgical specialties, you start to have them there. At some point, even in those facilities, now you start to have advanced services in terms of physiotherapy. You start having advanced imaging, MRI, CT scan. You start having advanced surgeries, the orthopedic surgeries, that's the one I was forgetting. And then now at level 5, now then you get a notch higher in terms of the super specialties now, not just the specialties.
Explain super specialties.
So super specialties, you start having, neurosurgery. You start having especially critical care. And critical care surgeries, that's where you start having cardiac surgeries, that's where you start having also oncology and advanced oncology. So now it's not all these hospitals you can do, for example, screening for cancer, but when you're talking about real treatment, for example, surgical oncology, when you have cancer and there has to be a surgery, then now it's at level 5.
Right.
Yeah, yes.
And what's the level 5 facility in Nairobi?
So we don't have a level 5 facility. We are just about to open one in Mathare, Korogosho. Yes.
So far what we have is level 4.
So far, Nairobi has never had level 5. It's one of the big, the only, out of the 10 former provinces, Nairobi is the only one that didn't have a level 5. It's such a interesting story.
Bagathi is level 4.
Bagathi is level 4.
Imagine. We didn't have a PGH. Our PGH was Kenyatta.
Our PGH was Kenyatta, which is a level 6.
Which is a level 6. Yeah.
And so you can see why Kenyatta was having problems. Because Kenyatta had to do the work that's not meant for it.
All right. So then with these 17 and the 15 then that have been commissioned, all of these things which you've told us about, you said now of the 3 Bs, Are all of them 3Bs of the 15 that are ready to go, or is there a mix of?
There's a mix.
Okay.
So of the 3Bs, of the 15 that have been commissioned by His Excellency the President, 9 of them are 3Bs,
Okay.
and 6 of them are level 2s.
Okay.
Yeah, but I'll tell you an interesting factor that we've seen. For example, in Gatina, where the hospital has been commissioned, or even in Kiamaiko, which are level 2 facilities, they see more patients than the level 3Bs.
Really?
Yeah.
Okay.
Which is
So-
how it should be.
Which is how
Which
it
is
should be.
Because
Yeah.
we have more and more people presenting
Yeah.
with these issues that can be taken care of
Yeah.
at a dispensary level facility.
Exactly.
Right?
But also what we have done, Nairobi is a unique place. Nairobi city generally, everyone or nearly everyone that has come to Nairobi has come either for work, and nearly everyone that is in Nairobi is somewhat enlightened. We have the highest levels of literacy. So, and also because of the nature of the population, what we have done is to actually integrate what we are calling the policy. So we are not even following these levels. So for example, in Zimmerman and in Kayole, where we have the level 2s, what we've done is nothing stops us from taking pediatricians there, because it's just a room. It has a good laboratory. So what we've done is that we are taking a pediatrician there. He sits there and sees the children. You find that in a level 4 service, but we are giving it in a level 2. So basically, we are also challenging the policy a bit, because we have to respond to the needs of Nairobi.
So essentially what you've done away with traditional structures.
Yes,
And you've structured it depending on the needs that you have seen.
exactly.
Task shifting.
Yeah, because we find that, for example, if Mama Lucy Kibaki Hospital has, and sometimes they see up to 3,000 children every month, Mama Lucy Kibaki Hospital, and there's crowding there, it's a bit of difficulty, then we take that same service to Tasia, or we take that same service to Kayole, Soweto, or we take it to Kiamaiko. And the pediatrician can sit there, because all of us know, if you take your child, I know Upper Hill is where there's the highest concentration of clinics, for example, and parklands. Any Nairobian taking their child to a private facility, there's only one thing they need. They need a pediatrician sitting there, and most of the time that pediatrician sends for a blood test called a complete blood count. That's like 99% of any child who is sick with a fever, 99%, and I can say this authoritatively as a doctor, and they can listen. That is what happens. They come with the homa, they have a fever. Most of the time, what is it? Let's do a complete blood count to check whether there is an infection or something in the general clinics. Nothing has stopped us from giving that service, and that's what we have done. So we have put, for example, this complete blood count test in a level 2 facility, and we can have a pediatrician sit there and do the same thing.
Okay. Doc, I've got to ask, because when we saw, because like we said, highest number at one time of facilities being erected, established in ever, right? Yeah. And then the question was, in our minds, I think we sat in this room and we said, wow, okay, that's a lot. Has the county, has the NMS been able to adequately fill them? So we've got the skeleton, is the meat there? So in terms of infrastructure, in terms of personnel, in terms of capacity, have we been able to make sure that these are fully functional? You will not go there today or go there tomorrow, anyone, wherever it is, and say that we do not have medicine, or we do not have this personnel on staff, or we do not have this equipment that we need at a level 3B, for example, that imaging is not available because this equipment that we needed is not available. Do you see what I mean? What has been the bane of negative capacity for the health system previously? Would we still see these issues?
So I think there are two answers to that question. One is the fact that we're starting from a point where there was no hospital. And two is every single of these 24 facilities. By the way, they're actually slightly more than 24, but we can just talk about 24. If you look at the total number of facilities that we're doing, the 24 are the ones that are presidential directive, sort of as a response to this problem that Nairobi has had. And let me also sorry, let me digress a bit to something that is important. In the 1990s, there was a huge expansion program of health facilities in this country. Nairobi and Mombasa were left out. And that's where sort of the problem started to be. So as the population was expanding and many other counties, for example, if you look at Vihiga level 4, if you're looking at the new hospitals, they were built somehow between 1988 and the 1995s. And that's the time that there was a very huge program for expanding facilities, what we now call county referral or the level 4s. So Nairobi was left out, Mombasa was left out. Again, when we came to the economic stimulus program, there was something that we were calling model health centers. This was during the Kibaki presidency. And the model health centers, again, every single constituency in this country had what we call a model health center. They were big. Imali is just here on the road. If you're looking at the closest that we're having, Lari Health Center also in Kiambu. So those are the closest that you're having. But many counties then, or many regions benefited. Again, Nairobi was left out. So Nairobi having been left out twice, you can imagine the exponential population growth from around 1.5 million people in the 90s to now we are doing 4.5 million people in the night. That is the people who sleep in Nairobi. But in the day, we are doing 7 million people because all these guys from Kitengela, from Rongai, from Machakos, all people come to work in Nairobi, but they stay out of Nairobi. But they seek health services in Nairobi. So from a planning perspective, we are doing 7 million people. So you can imagine you're having infrastructure of 1.5 million people for 7 million people. So this was part of the biggest challenge. And then now we were analyzing just three things for selection of the locations where we're putting the hospital. Number one was the disease burden. Number two, of course, was the population. And number three was the number of people who come from that place who go to Kenyatta National Hospital and they get stuck. And this was done by the Nairobi Regeneration Plan. There was a huge committee that was done. That was 2018. And they had a very good report. And if you look at that report, it's very detailed. For example, in terms of referral rates from Kayole or referral rates from Mukuru. And if you're looking at Mukuru with a population of 500,000 people, they had no single health facility. What they are calling Mukuru Health Center is in Imaradaima, which is not Mukuru. So you find 500,000 people living in one area, no single health facility. If you analyze the number of people who get stuck at Kenyatta National Hospital, either because they have been admitted there, they can't pay the bills, and they have to keep having a bed there. They were from these regions. So we were using that data to sort of locate where are we going to build the hospitals. And we just use those three parameters only: the disease burden, the number of people who go to Kenyatta National Hospital, and the population density. And if you're looking at the places that we've put either a level 2 or a level 3, the population that they are serving, in terms of that small catchment, is actually more than 60,000. But if you're looking at the level 3s, they are serving a population of between 300,000 and 500,000. So this is huge.
Let's take a break. Let's take a break and then you'll ask the question. It's 28 minutes to 8. This is Kenya's biggest conversation, the situation. And we still haven't answered.
I've not answered the question.
So are these hospitals equipped?
Functional.
Are they functional? Do they have the requisite number of healthcare workers? Dr. Ouma Oluga is in the studio with us. He's the Director of Health Services at the Nairobi Metropolitan Service. We are talking about the 24 new health facilities that the NMS is putting up in Nairobi. 15 of them are already operating, according to Dr. Oluga. He's explaining to us how, where they are, and what kind of services they're offering. Conversations to have with Dr. Ouma Oluga, Director of Health Services at the NMS, talking about the construction of the health facilities. So before City comes in with this question, finish responding to Ndu's question, which was, are they equipped?
Are they equipped? So yes. So first of all, these facilities have been done as a turnkey. Turnkey means that you don't do the construction and then you start going to look for equipment. Then you start going to buy an ultrasound from one person, you find it's not functional, and then you buy an X-ray from another person. So it's basically turnkey. And one of the best things under the UHC. And I think this is something that we need to upload. Sometimes I think there are things that are not said. There's already a code for equipment with specifications that need to be done. And we borrowed this from the Ministry of Health, by the way, and we want to really appreciate that there was that infrastructural standard as far as equipment was concerned. So there's already a code, for example, UHC 1, UHC 2, UHC 3, as far as every single machine that you need either in the laboratory or in the imaging department is concerned. And we just pulled this and we used it. And I believe, I hope that other counties can just pull it from the ministry and use it, because it solves a lot of problems. You don't have to go running around trying to look for everything, what needs to be in a level 2, what needs to be in a level 3. There's already a package of what needs to be in a level 3,
And the Ministry of Health has this.
The ministry, we
developed it.
Yes.
Yes, they have it.
They have it,
Very
yeah.
interesting
And they've had it for some time.
And they've had it for some time.
Do you know how long they've had this for?
I wouldn't know, but it's good that they have it, and because it's a really good thing. I think also sometimes because of these issues of devolution in terms of the push and pull between national government and county government, there are some things that are ignored. For example, it's the work of the ministry to set standards, and I think we need to recognize that. So sometimes we don't recognize that, and then something that is good like that is passed. So basically, they are fully equipped. Fully equipped.
So turnkey means
yes.
that were you giving a project per facility, or was it the entire facility and saying?
Well, for these ones, of course, it was the entire.
Right.
But even if you were to give per facility, then it would still be the building and then the equipment,
And then
because
equip it.
that standard is already there.
Okay.
And that solves a lot of problems, because then you don't have to have different standards for different equipment, for example. And that's especially coming to where you're talking about functionality. When you are to make a hospital operational, there are two things that are very important. One is servicing of machines, and two is making sure that there are enough commodities for those machines. So the servicing part, usually also you find you go to a hospital, the x-ray is broken, the part has to come from Germany, and then the ultrasound is broken, the part has to come from India, and the engineer is not here, all these kind of things. So if you do all of this as one, then you find that the servicing contract or the servicing of the machines is simple. Is uniform. Going to the issue of commodities, of course, I started by saying that we are starting from a point where the hospital did not exist. So, there has to be also a complete change in terms of this policy. So what we are doing right now is we've made sure that the hospital is there, the equipment are there, the health workers are there. We have employed 2,000 healthcare workers. We've employed 200 doctors, 179 clinical officers, 780 nurses, 100 laboratory technologists, 100 nutritionists, 100 physiotherapists, and social workers. We've employed nearly 200 support and clerical staff to make sure every single hospital, and again, I think this is the first of our facilities, if I'm comparing them with the old Nairobi facilities, that have what we call the minimum. We have met the ratio of what the WHO set standards on, what we call the work indicator staffing norms. So workload indicator staffing, or the WISN, if in the scientific terms of staffing hospitals, they have all met the standard, because we were looking at the population, we were looking at the disease burden in terms of workload, and we were trying to calculate. So if you go to each of these level 3s, they have 5 doctors each, and they have 5 clinical officers, and they have 39 nurses in the level 3s. If you go to the level 2s, again, that number comes down. They may not have doctors, but they have 2 clinical officers, they have 3 lab techs, they have 25 nurses, because of also what we are trying to do. So we have used the staffing norms at the international level to make sure, and that's how the number 2,000 was coming about, and we have made sure that they're well staffed. Now, as far as commodities are concerned, that's something that also we have to really work on. I wouldn't say that we have already struck the chord, but we already know what we're going to do in terms of frameworks, because the Act says that you must get things from KEMSA, and so KEMSA, of course, is the backbone in terms of that supply. But I think there has to be a wider conversation in terms of re-engineering that supply chain to make sure that the doctor is not there, the nurse is not there, the x-ray is there, the hospital is there,
But they
and then
don't
you
have.
don't have gloves. Yeah, so that is what we are really working on right now. But for me, I think we've done the 75, 80% of it, and that's now the smaller bit of it. Now, in terms of sustainability, because that's a sustainability question, we are also looking at having these facilities have their own income. And with the UHC, we have already registered 66,000 families in Nairobi, for which there is already a payment of 6,000 per family at a cost of around 400 million. So basically what this does is that every single of these people, and they are the most vulnerable, in the UHC terms are called indigents. So selected again across the whole of Nairobi. We went round and we registered 326,000 of families that we thought are eligible for support as far as NHIF is concerned. So that
What criteria did you use?
So the criteria, there is a tool already. There is an SPSS tool, basically a social protection, social services tool from the Ministry of Labour that ranks the poorest families, and it has 11 parameters. It has from your income, it has whether you have disability, whether you have a chronic illness, whether you have an orphan in that neighborhood, whether the kind of house you're living in, whether there's someone there who has an income, and what sort of an income, whether it's self-employment, whether it is formal employment, and all of that. And this tool is very, very good. The World Food Program, we used this tool also when we were doing the COVID-19 support. And the World Food Program, they came and audited our system, and they said 99% good, because you've not had a single complaint of people saying,
I'm not of this
I
bracket.
am not. Yes. We went to Kibra and Ngomongo, for example, just did a community, what we call community validation, where we said, these are the people that we have put in this program. Can you please confirm for us if these people are living here with you? And, you know, when the elders came, the Nubian elders from Kibra, and they said, perfect.
So in essence, you're saying we have the tools that have mapped out the vulnerable in our society.
Yes.
In Nairobi or in Kenya?
This tool can be applied
SPSS
in
is
Kenya.
countrywide.
It's countrywide. It's countrywide because the tool is from the Ministry of
Yes.
Labour. But for us, we have used it in Nairobi, so I can speak only about Nairobi.
Yes.
Yeah.
That is exactly what I was asking, because the tool I know exists.
Yeah.
So the question I wanted to ask,
Yeah.
with this knowledge and with understanding the burden of disease that we have among the most vulnerable in these areas, what policy does this section that you had have on approaching healthcare from a preventative perspective? Because it is good you have the hospitals.
Yes.
It's good that when you need them, they're there.
Yeah.
But isn't it much better to ensure that people don't get sick?
I think you just got back to where we wanted. So, you know, we launched the Community Health Services Act in Nairobi just a month ago. And we have mapped out Nairobi. So basically, Nairobi is also a bit unique. So let me just say this. So 77% of Nairobi, you can map it out as far as, estates, residences are concerned. And then there's a 23% of Nairobi that is a bit, let me use the word affluent. So, for example, if you're talking about preventive healthcare and promotive healthcare, where you're going to promote lifestyles and all of that, of course, it's much wider as far as our roads are concerned, as much as the whole economy, also money and all that. But now breaking it down to specific health issues, where we are going to be promoting health, we're going to be promoting life, we're going to be going to the communities to sort of make sure they are living healthy, sanitation, water. We've done a community health strategy in Nairobi, and we've launched the Community Healthcare Act. And we've the 77% of Nairobi that we are talking about, that is from the mid-level estates, the Langatas, the Zimmermans, the Kasaranis, going all the way to the informal settlements, the Gomongos, the Kibras, the Madares. Yeah, we've done 732 community healthcare units, and each unit has 100 households, and each of this is manned by a community healthcare worker. And we have 7,320 community healthcare workers that we have also validated. And for the first time, we have registered them to be, so that we recognize them, so that someone is not just walking to your place and they're calling themselves a community healthcare worker.
Yeah.
There is no identification.
Yeah.
No one can claim to know them. So we can verify, for example, that if Oluga comes to your place and they claim to be a community healthcare worker, we now have a database, and we've gone through together with the chiefs and together with the facilities, because there has to be a linkage in the facility, and together with the households, and we have a register of 7,320 community healthcare workers, and they report through a tool we are calling MOH 514. Basically, we've mapped it out, and we have given them three main work. Now,
Okay, go ahead.
one is the linkage to the facility. So basically, if there is, and I told you we already know the disease burden. For example, in Kibra, we may already have assessed that the number of people, children in this place that have epilepsy, that are going for a clinic in Bagathi, are this number. And we know the households, because if a community healthcare worker is in charge of 100 households, then it's very easy to know in that household there's a child with asthma, in the other one there's a child with epilepsy, in this other one there's an old man with
So
stroke.
I have to ask,
Yeah.
what training, what experience, what background do you demand of these community health workers?
The community healthcare workers have a curriculum that again was approved by the Ministry of Health long time ago. And for us in Nairobi, as I mentioned to you, Nairobi is a very literate society. What we have done is that we are using community healthcare workers on only three aspects. Number one is advocacy, giving the messaging. So if there is a family household with hypertension or a stroke, then the work of the community healthcare worker is to go there and to tell them, you need to go to the clinics every 3 months. Which clinic are you going to? Are you attending your clinics well? So in terms of that advocacy, in terms of diseases, today is World Hypertension Day. Are you taking your medicines? And those
So
kind
what's
of.
the
Number
training?
two,
Yes.
so there's a curriculum on that. There's a
but
curriculum. Yeah.
What I'm actually asking,
yeah.
I understand the curriculum,
Yeah.
the content of the curriculum that equips them to do what it is that
Yes.
is demanded of them.
Yes. So the content of the curriculum is in terms of, number one, health messaging, and number two, we are not going into the details of the disease. So we're not making them doctors. We're not making them nurses. They are not interacting with the medicines. They are not doing any treatment. So basically, their work is to link you with the healthcare facility. Number two is to mobilize the community. For example, during COVID-19. Vaccination. Nairobi is at 32%, I think you've seen. And of course, that's the highest. It's not by chance. When we were doing polio vaccination, for example, we reached 1 million children in less than a week. And it's not by chance again. It's again the structure. Because we know a way of mobilizing. So every community healthcare worker, for example, already knows that in this household, they are under 5s. So when our nurses are coming with the vaccination, it's very targeted because they know I am going to go to this estate. There are already this number of children who are under 5. So we are not doing guesswork where someone is just walking and knocking. Kuna mtoto hapa under 5. So that is what we are not doing. And that is what we are also when it comes to vaccination, for example, for COVID, we've had the highest consumptions in Nairobi. And we're generating interest because of that mobilization. So if the community healthcare worker knows here, let's say the target population for COVID-19 vaccination initially was the healthcare worker, the risk. They know that you are at risk. You need to go for the vaccination. The vaccination is in that facility. So they sort of create demand creation. So the content of the training is in, and we do a lot of trainings, of course, thanks to also the partners, the UNICEFs and all that. We do a lot of that training, and it is basically in demand creation in terms of advocacy and linkage to the facility.
Does it help if these health workers actually reside in the areas they're working in?
They do.
So it's a basic requirement that they must reside in the area.
They must come from there. If community healthcare workers in Eastleigh are people who reside in Eastleigh. And that is why one of the criteria, of course, you must be a Kenyan citizen. You must be vetted by the chief. You must have a certificate of good conduct. You must have done this work for a year, because also we are looking at the passion. It's volunteer work, although we compensate them. For the first time, we are compensating them with stipends.
How much are you compensating them?
So we compensate them per activity. For example, when they did the UHC registration, they are the ones who went round and did the UHC registration. And then we took the list to the Ministry of Labor to sort of also validate. And you know what? They validated the list because when they were going through the tools, it was accurate. And so when we reimburse them based on an activity, for example, we can do 500 per day for when we are doing an activity, if it's taking 2 weeks. During the polio vaccination, we also reimburse them based on the number of days. And we find that better because it's performance-based reimbursement.
Right.
So it's not just paying someone for sitting
nothing,
there,
really.
you know.
Mm-hmm.
So if we look at all the work that has been done then by the NMS over the last 1 year in terms of increasing access to health, actually, before I go to that question, there were existing health facilities already in Nairobi.
Yes.
So have you also re-equipped those facilities? Have you increased the number of workers, of staff working in those facilities? The old facilities.
So yes, the old facilities we have done. First, this Nairobi regeneration plan that was through the assessment that was done in 2018 mapped out around 10 high volume facilities that needed upgrading. So that we've done. So for example, Kibera South, we are doing a theatre in Kibera South because Kibera South is a small facility, only 12 beds. But very high volume as far as maternity is concerned. So you cannot decongest Mbagathi without improving Kibera South facility. If you're going to Kangemi, again, a very highly populated area, an existing facility, we are upgrading that facility. Babadogo in Ruaraka, that's one of them again. We are upgrading, we are putting a theatre there and making sure that we are expanding the maternity. If you're going to Muthui on the far end of Dagoretti, we're doing, that's now a huge project because we are doing there almost 80 bed capacity hospital because Muthui was built by the CDF when Beth Mugo was the MP there. And it's a small facility. So if you're looking at that far, they have to come all the way to Mbagathi. So again, we're expanding those old facilities, making sure that also we are equipping them. Of course, this is not going as fast as the 24 because the 24 was more a rapid program. As I mentioned to you, we were really in bad shape as far as COVID is concerned.
Something needed to happen.
Something needed
Very
to
fast.
happen.
How much
very
did it
fast.
cost for this thing to happen?
So the 24 ones are in total cost was 840 million. Yeah. So basically a level 2.
840 million for 24 facilities.
Yeah. Basically a level 2 facility at we are looking at construction and equipping at 30 million and a level 3B construction and equipping at around 57. And this is a turnkey. So this is also quite cost cutting if you're looking at the usual construction issues. And I think for us, the most important thing is not even all of this investment, is the impact.
Right.
If you're looking at the number of people...
Did this money come from the national government or was it part of the Nairobi County government budget?
I think,
Or it's from both?
Somehow I think it's from both.
Okay.
It's from the government. It's government.
Government money.
You know why I'm asking this?
Yeah.
Is because the NMS has calendar dates.
Yeah.
All right?
Yeah.
There is a date when the governor signed off
Yes.
some of these functions, and there's a constitutional date where these functions then revert to the county government. So basically what we're saying is after next year's general election, the Nairobi City County comes back and NMS sort of whatever happens to it. Now, is the county government, from your assessment, going to be able to take up some of the work that you've done in the last 1 year and carry on with it?
I think apart from myself, who is new, everyone else that I work with in the health directorate is
Has
from
been
the
there
county.
before.
Has been there
Is a
before.
county
So
worker.
we haven't brought any new person.
Okay.
It's just I think just myself, and the team is actually amazing. And I think we have to look at, for me, and I have to say this, I think for me is what I have learned from NMS, and especially from our leadership, Lieutenant General Badi, is that if people are enabled to work, they can work.
If they are enabled, I think is the
Yeah.
right there.
Yeah.
So that was the problem.
Yeah.
So I
Part of.
and I think that's for me, that's the thing, that we civil service can work and that public healthcare can work. And if you have a leader like my boss who of course gives you targets and is very visionary in terms of what has to happen, but also the environment is right for you to work, you work.
There's political goodwill
Yeah, you are.
across the board.
So there's absolutely no excuse for not working. And that's why I was talking about the impact, because these facilities, for example, if you look at each one of them, they are seeing between 200 and 300 people every single day. The question is, where were these people going before? And
If
so
they were
fa-
going.
If they were going. And so far, we've attended to 100 and more than 160,000. If you, Kibra was just launched the other day, Kibra Level 3 facility. It's one of the biggest of these ones, slightly modeled differently, around 30 beds, not the usual 20. Seeing more than 250 people every day. Gatina is 200 people. Kayole here is, we're doing 150, 180 people every day. So if I give you the statistics, all these people are going to the facilities and they are getting care.
So there's access to healthcare.
There's access to care.
Improved
Yeah.
access
to
healthcare.
and it's access in the complete term of access, not access where the facility is there,
Not you
but
go
the
to
service is
not
not
you go to a healthcare
Yeah.
facility, but there's no doctor, there's no nurse, there's
So
no medicines.
So that's this, and that's for us the most important thing. Of course, sustainability is something that we are now
That's
have
the
to look at,
impact.
and that will, I think, now
We'll talk about it in coming days. Dr.
the
Ouma
senior
Oluga,
people.
thank you very much for coming today.
Thank you, my
Come
brother.
again soon.
Asante. Thank
Asante
you.
sana.